Welcome back to Diabetic Foot Files. This is our second episode of Limb Watch, a movement that is dedicated to wound intelligence, prevention science, and limb preservation. I'm your host, Dr. G, and today we're joined by one of the true pioneers in podiatric medicine and limb preservation, Dr. Matthew Garoufalis. So Dr. Garoufalis is the past president of the American Podiatric Medical Association and is the past president of the International Federation of Podiatrists. He is a clinical associate professor of podiatric medicine and surgery at Western University of Health Sciences in Pomona, California, and he is a current member of the International Association of Diabetic Foot Surgeons. He is a graduate of Scholl College of Podiatric Medicine and completed his podiatric surgical residency at Westside VA Medical Center in Chicago. He also has a private practice in Chicago and is part of Advent and University of Chicago Health System. Dr. Garoufalis is board certified by the American Board of Podiatric Surgery, as well as also board certified in by the American Board of Podiatric Medicine with added qualifications in wound care and limb preservation. Dr. Garoufalis is also the immediate past chair of the Alliance of Wound Care Stakeholders. Dr. Garoufalis is now the Chief Medical Officer of Advanced Oxygen Therapy. He is also the current president of the American Board of Podiatric Medicine International. He is a noted and award-winning researcher, educator, author of many articles, and as an invited guest speaker, has accepted many speaking engagements for educational lectures, seminars, and workshops, both internationally and nationally, on a variety of topics pertinent to wound care, limb salvage, podiatric medicine and surgery, as well as practice management. He is considered a key opinion leader in many areas. So today we welcome Dr. Garoufalis to Diabetic Foot Files Limb Watch. Welcome, Dr. Garoufalis.
Thank you, Gabby. It's a pleasure to be here with you.
Oh, thank you so much. So Dr. Garoufalis, he's actually going to help us break down the science, the clinical applications, and the future of topical oxygen in diabetic foot care and limb salvage. So first question is, Dr. Garoufalis, you've held some of the highest leadership roles in podiatric medicine and wound care. How has your perspective on chronic wound management evolved over your career?
Well, it's amazing because, wound care used to be the afterthought. Nobody wanted to go into wound care because it was the not so cool, not so sexy thing to do. Everybody wanted to do surgery and the cool stuff, sports medicine, things like that. I got into wound care because I did my training in the VA and I stayed on at the VA as an attending as I started my private practice. So in the VA, for everybody that's ever rotated in a VA, you get some great experience with medicine. These are veterans. God bless them and thank them for their service. But they present some very special issues for all of us in training and for all of us that are teaching others about medicine, because they have some very unique issues. So wound care in the VA is really a big deal. And as much as I wanted to start my private practice in sports medicine and in surgery where I was trained, I ended up gravitating towards wound care. And then this whole limb salvage thing exploded and took off like a rocket. And now that's really a big deal. And that has grown so much over the last 10 or 15 years. It's really remarkable to see it's not just wound care anymore. It's limb salvage, because we're doing more than just healing wounds. We're reconstructing these limbs for our patients, allowing them to ambulate. That's the whole goal. Giving back to the patients the ability to move, gives them their freedom and gives them an opportunity to live their life. So it's not just wound care. It's about limb preservation and limb salvage and giving them the opportunity to move again. And that has developed over the past 10 or 15 years in podiatry. It's gotten bigger and bigger. And so as a result, we're seeing these fellowships now in limb salvage. We never saw a fellowship in limb salvage. It was always surgery, Lizarov or some advanced surgical techniques. Now we're seeing all kinds of fellowships in limb salvage because it's such a big area. So that's really how the profession has evolved in the last 10 to 15 years in a big way.
Okay. So, in your clinical view, what is the most underappreciated driver of non healing diabetic foot ulcers today? Is it ischemia, infection, inflammation, or metabolic dysfunction?
Well, I think it's actually all those, but we need to understand how they all intersect. Metabolic dysfunction is probably the weakest link there that we need to understand better.
Mm,
And this is a function of the diabetic patient, diabetes, and we need to understand what diabetes is doing to our patients from a chemical point of view, from a
mm,
metabolic point of view, and why their systems begin to deteriorate because of their unchecked diabetes.
mm,
Someone asked me, a few years ago, if you have a diabetic patient, are they doomed to dysfunction? And I said, well, they are doomed to dysfunction. Every diabetic patient is doomed to dysfunction to a certain degree. It depends on how they take care of themselves.
mhm,
And that's the problem with our diabetic patients is they don't take great care of themselves. We see this in the VA all the time. We see it in the underserved areas of our country. They
mhm,
don't get great care, support care, and so they don't get great health care. And so their dysfunction complicates, it builds, it gets worse and worse and worse to the point where they can't recover sufficiently. So understanding the metabolic dysfunction also leads then to your ischemia, your
mhm,
infection, your chronic state of inflammation, all that. So if we understand what's going on metabolically, we can begin to control some of these other issues. Staying under control, a diabetic under control with good blood glucose monitoring and good diet,
mhm,
those are the patients that we don't see getting wounds.
mm,
They those are the patients that, yes, there is some dysfunction going on because of their diabetes, but it doesn't proceed as rapidly as those patients that we see in our clinics, that we see with wounds and we see with ischemic problems. Those patients have it's gone a little bit too far, and so things have gotten out of
mhm.
balance there. So
Yeah.
the limiting factor is staying under control, getting good care, but we also know that there's a lot of issues with getting that to happen with different populations in different areas. That's the most challenging thing.
Yes, you're very much correct. So, how do you conceptualize oxygen deficiency in a chronic wound environment? Do you see it more as a perfusion problem or a cellular utilization problem or both?
Actually, it's both. It's a perfusion problem on one side because we aren't able to deliver oxygen to the wound to get it to close because of the metabolic dysfunction, the ischemia, infection, inflammation. The circulatory system has broken down, and so we can't get oxygen to the wound. But then at the same time, when we do get oxygen to that wound, we need to make sure that the wound and the tissues are ready to accept it so that they
Mm,
can optimize that oxygen and start that cellular machine functioning again. So even when we supply oxygen to a wound, whether we do it through hyperbaric oxygen or through topical oxygen, it takes a little time to get that wound up and going. It's going to take a week, 2 weeks, or 3 weeks to reach optimization so that wound begins to respond to their new oxygen level. And
mm,
what I see many times is when we apply oxygen therapy, providers are very impatient. They say,
mm,
"Oh, we're going to use oxygen, and this should be good by in a week." I go, "No, it's going to take longer than a week. We have to build capillary beds. We have to have the
mm,
tissues understand how to receive this oxygen, and the chemical reactions have to get geared up once again to where they were so that they can do the enzymatic reactions and perform the functions that they're supposed to perform. But we have to reduce inflammation and infection in the meantime in order for that to happen. So it's a process. It takes 1 or 2 or 3 weeks, even with oxygen therapy, before we can really get the ball rolling.
Okay. I'm pretty sure this might be a little double of a question, but can you walk us through the mechanism of topical oxygen therapy at a tissue level? Like what is actually happening to the wound bed when it's applied correctly?
Oh, sure. Boy, we can spend about 3 or 4 hours on that. And we can really get deep into the weeds here in chemistry. But let me just give you an example of a few enzymes and how they're affected by oxygen therapy. And this is just a thumbnail sketch. Let's look at NAPDase oxidase. NAPDase oxidase is the enzyme that provides us our functioning leukocytes and neutrophils and helps us to fight infection. When we add oxygen to NAPDase oxidase, we begin to upregulate that enzyme. When we upregulate that enzyme, not only do we get upregulation of our neutrophils and leukocytes, but we also get an upregulation of one of the byproducts that NAPDase oxidase breaks down into, which is hypochlorous acid.
Mm-hmm.
So we know that hypochlorous acid is responsible for changes in pH. And there's been lots of articles written about if we can change the pH of a wound, we can get that wound to close. Most chronic wounds are very alkaline in nature. So if we can produce hypochlorous acid by upregulating the oxygen concentration, upregulating NAPDase oxidase, we can change the pH of that wound and defeat biofilm, bacteria, and bioburden, which is one of the things that we do, which is why when we use this two therapy, we begin to see a slough appear. And again, providers say, oh, look, you caused my wound to begin draining all this yellow and green gunk. I think it's infected. I think you made it worse. No, this is supposed to happen. The hypochlorous acid is actually cleansing the wound and kicking out all that biofilm and all that bacteria and the bioburden. So we expect to see increased amount of drainage that first 2 weeks as we cleanse the wound with the hypochlorous acid, drop the pH down, and then we begin to see healthy granulation tissue. One of the other enzymes that we affect in a positive manner, in a very cellular way, is ATP synthase. It's full of oxygen receptors. And when we add oxygen to ATP synthase, this is, if you remember back in school, remember the Krebs cycle? And
Yes.
sorry to bring up the Krebs cycle.
Yeah.
Nightmares for a lot of people.
Yeah.
But that's what we're actually affecting. We're increasing the effectiveness of ATP synthase and producing more of it. So this gives more energy to the mitochondria to produce more enzymatic reactions. We also upregulate the fibroblasts with oxygen, specifically prolyl hydroxylase and lysyl hydroxylase. These are the building blocks for collagen. So if we can build a stronger collagen and better cross-linking of the collagen, we're going to build a better healed wound that has durability and decreases the chances of reulceration down the road by decreasing the amount of scar tissue that's formed. And so we have lots of studies that have shown that by adding pressurized oxygen to the wound healing cascade, we increase the level of collagen that is produced and decrease the reoccurrence of these wounds down the road. The most important enzyme that we see in the mechanism of action is, of course, the upregulation of nitric oxide. And when I speak to vascular surgeons, their eyes gloss over because they love nitrous oxide. They feast on nitric oxide because it helps with vascular repair. It's the key enzyme needed for angiogenesis, for capillary bed formation, and to decrease inflammation. So by pushing oxygen into the tissues and beginning to upregulate nitric oxide synthase, we increase capillary bed formation, increase blood flow to that wound, and decrease inflammation at the same time. So what's happening here is it's happening on a very cellular level. And at the same time all this is going on, we're decreasing inflammation, we're activating the lymphatics to drain the edema away from the wound. Because even even in a diabetic foot ulcer, we see some swelling and edema, but beneath the surface of the skin is profound. And that's one reason why these take so long to heal. But if we can get rid of the edema, activate the lymphatics, we then begin to get better healing. So there's a lot going on all at the same time with the resolution of the inflammation, the decrease of the edema in the tissues while we're building capillary beds and changing the pH of the wound. All this is happening at the same time. So yeah, the mechanism of action is very, very complex. There was just an article published. We call it therapeutic synergy because all these things work together at the same time. And we just published a paper in the Journal of Vascular Surgery talking about therapeutic synergy, and it dives very deeply into the mechanism of action of this topical, this it's called intermittent topical oxygen. That's what Medicare is calling it now.
Okay, so, intermittent.
Yes, that's what it's called, intermittent topical oxygen.
Oh, wow. Okay. So how does topical oxygen differ physiologically from systemic oxygen delivery or hyperbaric oxygen therapy in terms of tissue penetration and cellular effects?
That's a great question because what we do is we use some of the theories of hyperbaric oxygen. In hyperbaric oxygen, the whole body is put inside the chamber and the pressure is increased to about 2.5 times atmospheric pressure. And that way we can supersaturate the plasma and the red blood cells with oxygen. And the blood system then delivers oxygen to the site that it's needed, the wound. The problem is for most of the patients that you and I see, they already have a vascular system that doesn't work well. Mm-hmm. They already have a vascular system that is not getting blood to the wound, which is why hyperbaric oxygen in the patients that we see is not as effective as we would like it to be. It's beneficial, but not as effective as we would like it to be because the blood system is impaired and doesn't get the oxygen to the wound. So what we're doing with intermittent topical oxygen therapy, or TOO therapy as it's called, is we're increasing the pressure to just above 1 atmosphere. And then inside the chamber, because it's a portable chamber that we fit around the limb, we pump 10 liters of oxygen per minute. And then we're also using compression, cyclical compression, that acts like a pump to milk the edema out of the limb, but also to push blood up and down the leg. And it's the gas inside the chamber that's causing the pressure, not the chamber itself. So that's why we say it's non-contact cyclical compression. So it's actually quite comfortable and not painful to have this device on your limb for 90 minutes. So we're forcing oxygen into the tissues. We're causing a diffusion gradient. And that's why this is so much different than continuous diffusion oxygen, because there's no diffusion gradient in continuous diffusion oxygen. It's just oxygen that blows over the wound. And some oxygen does get into the wound and it helps it to close. But if we can actually force oxygen down deep into the tissues, several millimeters down deep into the tissues by a pressurized diffusion gradient, we can then put oxygen deep into the tissues and start this chemical reaction, this mechanism of action that I described earlier, to begin to get that to move. So it's when we use oxygen, just room air oxygen, that's not going to work as well because we don't have that pressurized diffusion gradient. This therapy allows you to use a pressurized diffusion gradient to actually force oxygen into the wound. And we have studies to show how effective that is and that we can actually make a difference within just a few minutes in the level of oxygen within the tissues. So that's what's really remarkable about this type of therapy.
Okay, yeah. So in your opinion, what type of wound phenotype responds best to topical oxygen, and which wounds are unlikely to benefit from topical oxygen?
Well, what we've done, in my experience, I was lucky enough to be one of the early adopters on this, and I came from a position of thinking topical oxygen was voodoo medicine. I came from a position of not liking topical oxygen very much. I had used it in the past, used different therapies in the past, and had very mixed results. And then this particular modality came across my desk, and I listened to the science that was available at that time and understood that it was okay. A little bit of hyperbarics, a little bit of compression therapy. I got that, and I decided to give it a try. So I started using it on diabetic foot ulcers and venous leg ulcers. That's the primary indication right now. But then as I got used to using it on those ulcers, here I am in the VA, and we have a very sick population. They have all kinds of wounds for a variety of different reasons. Thinking, well, have a pretty good handle on wound care. We know that this therapy is effective on these types of wounds, diabetic foot ulcers and venous leg ulcers. Let's start trying it on other types of wounds, like maybe post-op incisions that have dehisced. Wow, that worked pretty good. We got that wound to close very quickly. Patients with sickle cell, those wounds are very uncomfortable and they reoccur often. Wow, what a difference it made on those patients. So as we got more comfortable with using this technology, we began using it on more and more different types of wounds, to the point where now we can say, because we've used it on pressure ulcers now, on all kinds of wounds, abdominal wounds, post-surgical wounds, we can now say that it is good to use on all types of wounds. In fact, it's been FDA cleared for acute and chronic wounds. And that's the very broad definition that the FDA gave this technology, is it can be used on acute and chronic wounds, which opens up the whole gamut of wounds that we see in our clinics. And what's nice is it only has one contraindication, which is really unique. The only contraindication is if a patient has a DVT. Understandably, because of the pressure, you don't want to use it on a patient with a DVT. However, once they're on medical therapy for 48 hours, they can return and use this, and it's safe to use. And there's never been a complication from doing that. So what we've discovered over the past probably 10 years or so is that this is a therapy that can be used on nearly any type of wound to help it heal better, faster, and more durably. That's the key, more durably, because we've been taught in school that when you have a wound and it heals with scar tissue, then the tensile strength of that scar tissue is not nearly as strong as it was before. What we've been able to show with this technology is that patients that heal their wounds, because you can use this till closure, not like negative pressure therapy where you can only use it for a few weeks. You can use this therapy all the way until closure, because we're upregulating collagen synthesis and the enzymes that produce type 1 collagen. We're closing these wounds with a better grade of collagen, so the tensile strength is much higher. Our reulceration rates in the RCT that was published in Diabetes Care in 2020, the reulceration rate at 1 year was under 7% compared to the reulceration rate of the patients that did not get this therapy, which was at 40%. 40% just happens to be the reulceration rate that Armstrong published in the New England Journal of Medicine in 2017. So we were able to duplicate his study in the RCT published in Diabetes Care. But those patients that used this therapy had less than a 7% reulceration rate because of the durability of the collagen. There have since been other studies that have been done, a retrospective study that was published in a journal of the Vascular Society, showing recurrence rates of only less than 3% after a year.
Wow.
So this is something that's really interesting. I like to say that this technology right now is kind of where negative pressure wound therapy was 15 or 20 years ago. When negative pressure wound therapy first came out, people thought it was voodoo again. They're thinking, oh, you're going to put a vacuum on a wound and expect it to close? Come on, you're crazy. And actually, that negative pressure wound therapy actually killed some people because it was used incorrectly and they bled out. So it had a rocky start. But now, how common is it for us to use negative pressure wound therapy? And it's a huge market.
Yeah.
This technology is positioned in a place in wound care where we're exactly where negative pressure was 15 or 20 years ago. So it's very promising. We've had amazing outcomes, and the studies just keep on piling up. There's more and more studies being published all the time on this.
Okay, wow, that's amazing. Because I mean, I seen it firsthand when I was in residency, topical oxygen, and it would be these chronic wounds that the patients had for years, and then they started using the topical oxygen, and when they came to their weekly follow-up, the wounds were getting smaller, and I was just like, "Oh, wow, that, like, actually works." So, it
Yes,
was
you got a good dose of seeing it during your residency program. You
Yeah,
did a lot there.
so there is still some skepticism when it comes to, topical oxygen, oxygen-based wound therapies in the medical community. Because I always ask people, what do you think about topical oxygen? And, they don't know that much about it. So what do you think is driving that skepticism, the lack of evidence, the misuse, or the misunderstanding of wound biology?
Well, it got a really bad rap because there were some, witch doctors professing oxygen in a bag many years ago. Just wrap this bag and put this hose in there, and oxygen will help it close. And it was, hit or miss. And I used that therapy, and it was absolutely hit or miss. And there weren't any studies, and there were some really bad studies that were done with oxygen therapy. So it didn't get off to a great start. But in the last 5 or 6 years, there has been a tremendous amount of literature that has been published on this. It has gotten all sorts of systemic and meta-analysis reviews on this technology. And we're beginning to get some guidelines published based on the research that has been done. The American Diabetes Association, for the past 4 years, has given this therapy a level 1 rating, putting it in the same category as negative pressure wound therapy and skin subs.
Hmm.
The International Working Group of the Diabetic Foot, which does their analysis every 4 years, in 2023 gave this a thumbs up as an approved technology to be used for diabetic foot ulcers. The Wound Healing Society took a look at this in 2023 and also gave it a level 1 rating and gave the RCT that was published in Diabetes Care a grade A rating. That RCT, by the way, won an award for the best, one of the 4 best RCTs in diabetic foot care in the past 4 years in 2023. So it was pretty remarkable. Also, there's been guidelines that have been written by these organizations that look at research for therapies and then give it a thumbs up or thumbs down. One of those is ECRI here in the US. That allowed the big insurance company, we all know it's Cigna, to now begin covering this technology for those Cigna patients that have wounds. In the UK, the National Institute of Health and Clinical Excellence, which guides all therapies in the UK, gave this a positive rating. So now the National Health Service in the UK is using this technology. It also just passed in Germany, Germany's version of Medicare. They just gave it a thumbs up and passed it through. So now it's being used in Germany.
Oh, wow, that's
So
amazing.
in this country, Medicare is looking at it, and we're fingers crossed. We hope to have an LCD published by the end of the year so we can get Medicare coverage for it by the end of the year.
That'd be fantastic for patients because, that's a huge population for diabetics, the ones that have Medicare. So that'd be great for
Yes.
them to have that option. Okay. Can topical oxygen realistically shift the outcomes in a ischemic diabetic foot ulcer, or is it primarily effective once perfusion has already been optimized, like they have an angioplasty?
Oh my God. I can't tell you how many patients that we saved their limbs after the vascular service said, huh, nothing else we can do for these folks. We did a real world evidence study in the VA that was published in 2022 in the Advances in Wound Care. And it was a retrospective study, 200 VA patients. Half of them got oxygen therapy, half of them did not, just to see what would happen. But we took all comers. We took people that would never be allowed in an RCT. We took people with ulcers, UT ulcers grade 1s, 2, 3, and 4. We took ischemic wounds. We took patients with hemoglobin A1Cs as high as 19.
Oh my gosh. I didn't know that's feasible.
That's pretty high, right?
Yeah.
We accepted patients with ABIs as low as 0.3, patients on dialysis, and patients with all comorbidities, even 2-pack-a-day smokers were included in this study.
Really?
What we discovered is that, yes, these ischemic patients can heal, or you can limit the tissue loss that they're going to undergo in limb reconstruction. As a result of the study, we discovered that when we add oxygen therapy to the wound healing cascade, there was an 88% reduction in hospitalization and a 71% reduction in amputations.
Mm.
So that's pretty significant, because if we turn that around, we can say that for those patients that have a diabetic foot ulcer, if you don't use this therapy, there's a 9 times higher risk of hospitalization and a 5 times higher risk of amputation. So to answer your question directly, yes, even ischemic wounds can be helped using this technology. And when you have an ischemic wound, you know that it's all about tissue loss. You're going to have to do some limb reconstruction at some point, because some of the tissue's dead, some is going to live. You want to allow as much to live as possible. Some of these patients are going to undergo a DBA procedure as a last ditch effort to save their foot, but there will be some tissue loss. By using this technology, you can actually limit the amount of tissue loss. If you can get another centimeter or 2 centimeters of tissue to heal, that's going to change their entire postoperative gait pattern, and it'll make them easier to ambulate. And the prosthesis won't need to be as large. So, it helps by just a fraction, by millimeters and centimeters. If you can get a little bit more tissue, these patients are going to be much happier. So yeah, it can help even ischemic patients heal more, heal better, to save as much tissue as possible.
Wow, that's fantastic. So where does topical oxygen fit in your treatment algorithm? Early intervention, adjunctive therapy, or salvage therapy for stalled wounds?
Right now, it's classified as an adjunctive therapy. And when we have written the Medicare proposal, now that they're looking at it in Medicare, we're classifying it as an adjunctive therapy. So it doesn't change the way that you treat the wound. You still use good standard of wound care, and you still use the wound care products that you're using, because with the beauty of this technology is you don't have to change the dressing to use it. This can penetrate most dressings. So it's an adjunctive therapy. That being said, when the Medicare guideline comes out later this year, it's going to probably say that you have to wait 30 days before you can use this. So that makes it purely adjunctive. However, in the VA, where we don't have those kinds of restrictions, we were using it as a frontline therapy. Because we were so happy with our outcomes and what it was doing for these patients, we would order it for a patient on their first visit. They came into the clinic, they have the first time they have a diabetic foot ulcer. There it is. They're horrified. They don't know what to do. We order this right away, so they can start using it as quickly as possible to close that wound as quickly as possible, along with whatever topical products we're going to use. Typically, in the first 30 days, we're going to use a collagen or something like that, or iodosorb, something like that, to keep the wound clean and to help it fill in and close. But we're going to also use topical oxygen or 2 therapy in order to build that strong collagen and in order to change the pH of the wound so it can heal faster.
Oh,
So
wow.
in 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 the hands of where you don't have this kind of guidance, you can use it as a first line. So that's what's really nice about it.
Oh, that's fantastic. Because I remember when I first started this podcast, like one of the first ever people that reached out to me was a nurse, and I can't even remember where. I think she was in Chicago, and she heard episode on topical oxygen, and she said she believes there were patients that would help from that. And I was just like, oh, wow, that's amazing. Like somebody listened to the episode and wants to buy a plane to get some. And I reached out to you and I was like, can you help her find the reps for that area? So I'm also like super grateful for you always being so responsive when we're trying to get reps and
Absolutely. Yes.
how to get there. So
Yes.
in limb salvage scenarios, how critical do you believe oxygen optimization is compared to debridement, infection control, and offloading?
Well, I think it's part of the entire package. Debridement is a must. Um,
Uh-huh.
I'm a huge believer in debridement, and you must debride often. I can't tell you how many clinical studies I looked at. I'm an evaluator for a lot of different clinical studies. And I look at these clinical studies and the the product that they're evaluating looks like it's really a great product and it looks like it's going to be very helpful. But the product is not doing well in clinical trials. And the biggest reason it's not doing well in clinical trials is not because it's a great product. It's because your providers aren't debriding the wound for the
Uh-huh.
product to work well.
Oh, wow.
So
Okay.
debridement is paramount. You must debride. You must debride. This is this is what I say. You must debride every opportunity you get, and you must debride to bleeding. Now,
Yes.
not gushing, not gushing,
No, no,
but
no.
you must see a little petechial bleeding.
Yeah.
If
Mm-hmm.
you're not seeing bleeding when you're debriding, you're not benefiting from the growth factors in the red blood cells helping to close
Mm-hmm.
that wound, and you're not
Mm-hmm.
stimulating the edge effect.
Mm-hmm.
You must debride on every opportunity to bleeding. Then we have the offloading, we have the care, the metabolic care that they need, and then this therapy and whatever dressing you're going to put on there has to be the right dressing because now that the wound is debrided, it's going to respond to whatever you put on there and whatever therapy you're going to use.
That's absolutely correct.
That was a
So,
big problem when organics first came out in the late
mhm,
90s. It came out and it was, oh, the growth factor, the first growth factor that came out. And it was a godsend. And, oh, this is going to solve all your problems. And it was really expensive. And all of a sudden, within 2 or 3 years, it was dead. People
mm,
said, oh, it's a waste of time, waste of time. Well, no, it's a great product. People didn't debride. They just threw it on the wound. They didn't debride the wound because you had people that weren't trained that said, oh, this is a panacea. It's treating wounds. Why not treat wounds? I'm going to use this product. Let me just
mhm.
throw that on there without treating the wound, without debriding the wound. So wound debridement is key.
Okay. Wow. Thank you so much for saying that. So, what innovations, because it seems like you're always at the cusp of the innovations in wound care, are are you most excited about right now beyond topical oxygen?
Wow. We're going to be looking at gene therapy. Gene
Mm,
therapy is going to be really important. Peptide therapy in wound care. So we're going to get more specific about what part of the wound we're going to be interested in moving along. These peptides work in different parts of the chemical pathway in wound healing. So the early part of wound healing, you're going to use one peptide. Later on, you're going to use a different peptide. Same thing with gene therapy, depending on what you need, what the wound needs at this time. There's going to be different gene therapies that are going to be applied to the wound. So there's all this new technology getting very specific about the wound healing cascade. And that's going to be interesting because that is going to be incumbent on us as providers to learn and understand the deep, deep depths of the wound healing cascade and it all the way down to the chemistry. Now,
mhm,
that's going to turn a lot of people off because they don't want to go that deep into the wound healing cascade. But to really get it right, you have to understand what's going on
mhm,
at a cellular level. And we talked a little bit about that earlier. What's happening with the enzymes? What's happening at a cellular level to make this wound close? Or why isn't it closing? What's blocking it?
mhm. Yes, exactly.
We
So
see
for
that
mhm,
just using arginine, you know, take arginine.
a
Arginine is
supplement?
key, a supplement, right?
Mhm,
Oh, you know, people don't believe in it, but it's key for nitric oxide formation. If you're not supplementing with arginine, then you could be missing out on providing more nitric oxide to help close this wound.
Oh, wow.
Little pieces like that make such a big difference.
Oh, thank you. So for the younger clinicians entering wound care, what is the one principle you wish they understood about oxygen, tissue healing, and limb preservation?
Using oxygen will improve your outcome every time. No matter if it's a wound, no matter if it's surgery, no matter whatever you're doing, oxygen will improve outcomes. We started using oxygen therapy on elective surgery patients. Now that seems kind of strange, right? But it has the indication for acute and chronic wounds. But let's say you're doing surgery, an elective surgery on a patient, say you're doing a bunionectomy on a patient, mid 40s, but they're taking medications for high blood pressure. Maybe they're smoking a little bit and they're not going to quit for you, but they need their bunion done. Well, imagine how much faster that incision is going to close. And this is looking at oxygen down the road. If you were to use this therapy for just 2 weeks on that incision, you would never have a surgical dehiscence. Never in a compromised patient. So there's a lot of different uses for this coming. We just put a surgical patch together for this product specifically to treat surgical incisions with topical oxygen, with pressurized oxygen, because we believe that incisional therapy, just like you're using incisional therapy with negative pressure, you have that long, skinny negative pressure that you put on. The same thing is true of oxygen. You can close an incision using pressurized oxygen the same way because you're upregulating all these enzymatic reactions. And as a result, we can show that you're going to get a stronger, more durable incision closure by using oxygen because you can use it to closure, but you can't negative pressure. So we're initiating a study on incisional management that hopefully can get published in the next year or two, and that's going to have amazing outcomes as well.
So I have a question. So I really liked your comparison with it to negative pressure. What do you think that most likely you have to combat or needs to be done for it to become pretty much a standard of care? Because just like how negative pressure is standard of care now, like everybody knows it, even if you're not even in wound care. What do you think that what hump y'all have to go over so that it becomes standard of care?
Everything revolves around education. We need to educate the providers on how this works, and we need to make sure that it's easy to use, and we're making improvements on that all the time. The guidelines are helping. So we have some, as I mentioned about the guidelines earlier, they're out there. A lot of the organizations are publishing guidelines. Once Medicare approves this, then we'll have a lot more people using it. It will become a lot more mainstream and it'll become a lot more popular. But just like any new idea, any new treatment modality, it all hinges on education. So we've been doing a lot of education the past 5 or 6 years about this product, even before we knew it was going to get Medicare approval, because I believe that this is an up and coming product. I believe that it's going to revolutionize wound care. But you have to educate the providers so they understand why they need to use this and why it will make a difference in their patients. Right now, it doesn't have a physician pay component to it. So if you order it, you don't get any reimbursement by ordering this. With negative pressure, you at least get the change. There's a small fee for changing the negative pressure. What this is going to have with it, it's going to have a remote patient monitoring component with it when it goes live next year with Medicare. So the remote patient monitoring component will be interesting because you'll be able to monitor your patients both photographically and electronically by how often they're using the device. So there will be some reimbursement component there. So this is always being updated and modernized little by little as we go along.
Okay. So we're closing in. So this is going to be our rapid fire section, okay? So what's
Okay.
one diabetic foot mistake you wish every clinician would stop making immediately?
Don't hesitate to debride it.
Yeah.
Don't hesitate to debride it. You must debride diabetic foot ulcers. Get rid of all that tissue. If it's dead, it's dead. If it's not bleeding, it's dead.
Okay. So I asked another clinician this. What do you think is the most overused treatment in wound care?
The most overused treatment in wound care. Well, if it was last year, we'd say skin substitutes, right?
Mm-hmm.
This year, they're being controlled a little bit better than they were before, but they still have a lot of promise. And I'm a big believer in skin substitutes. I've used many of them on many of my most challenging patients. So there is definitely a place for skin substitutes, but people misuse this expensive modality too often, and that's a problem.
Yeah. Yeah, I saw some articles about that.
Yeah.
So what's one wound care myth that needs to die?
Wound care myth that
Yeah.
that Silvadene is good for wounds.
Mm.
That's a myth. Silvadene is the worst thing you can put on a wound. I go
Okay.
crazy when I see somebody putting Silvadene on a diabetic foot ulcer.
Oh.
Silvadene is for burns. Yes, it's antibacterial, but it is for burns. And
Mhm.
once you put Silvadene on a diabetic foot ulcer, it's very challenging to clean the Silvadene out of that wound so you can debride it. Silvadene does not belong in wound care. It belongs in burn care, period.
Oh, wow. Thank you. That's different. I wasn't expecting that. Okay. What's one thing you believe every resident should master before graduation?
Just one thing?
Yeah. Well, hopefully.
No. I believe me, I love my residents. I've residents my entire career. Um, I think they need to master communication.
Oh, wow.
Communication with the patient. That is
Mhm.
huge. If they can communicate with the patient what their expectations are and what the patient's expectations are, then their careers are going to blossom because medicine is all about expectations. Patients are coming to you to get their questions answered, and you have to understand what their expectation is. You have to manage their expectations. And if you can do that by educating them and giving them the knowledge they need to make good decisions with you, then you'll have a tremendously successful practice.
Oh, that's really thank you so much for saying that. That's, like, super helpful. I feel like I'm in residency right now because 'cause I'm, like, learning a lot. So, what is your favorite offloading device?
My favorite offloading device, well, I would I would have to say a TCC, but it's also
Okay.
the biggest pain in the butt device
Yeah.
because they're terrible to put on. But there are some great offloading devices on now that are coming out now. The different shoes and the big cam boots and all that are coming out now that are really very comfortable for the patient and the patients love to wear them because they're comfortable. The only catch with an offloading device is they can be taken off. That's the
Yeah.
biggest problem that we have with them is they can be taken off.
Mhm. That's so true. So, if you can change one healthcare policy tomorrow, what would it be?
Oh, I think to pay podiatrists the way everybody else is paid.
Aw, thank you. That's nice of you. Thank you. Okay. Okay, another question. I think I have 2 or 3 more questions. So, if
Okay.
oxygen is the life of tissue, why do you think so many chronic wounds behave as if they are oxygen starved even when a perfusion appears adequate? What are we missing biologically? I know you kind of covered a little bit about the metabolic cellular level aspect.
Well, that's what we're missing. We're missing there's something going on metabolically with that patient. And remember, many of our patients are on a boatload of medications.
Yeah.
We need as much as we hate pharmacology class, we need to understand the chemistry of of the the medications that our patients are on and how they interact. Sometimes we take it for granted that there's no interaction. But we know that there's lots of reasons why a wound is going to stall based on the medications this patient is taking. If we have a patient with arthritis and they're taking ibuprofen, we can't expect their wound to close very fast because
Yeah.
the ibuprofen gets in the way.
Yeah.
Are you going to tell the patient you have to be in pain for the next 3 weeks so we can close your wound? That doesn't go over real well. So you got to, again, manage expectations, talk to the patients, explain, how you can change his medication. Does he have to go on Tylenol for a little bit for, part-time Tylenol, less ibuprofen? Maybe that'll work. So again, understanding what's going on with the patient, understand what goes on in their life. That's huge. We don't ask our patients, what'd you have for dinner last night?
Yeah.
What'd you do last night? Because if they're having McDonald's all the time, we can't expect their wound to close.
Okay, this is the last question. If you can change one thing about how clinicians globally approach diabetic foot ulcers, what would it be?
Approach it with excitement. This is an opportunity to get that patient walking. You want to help them walk as soon as possible. So too many clinicians look at it with dread, like, oh God, there's a diabetic foot ulcer. Now we're in trouble. No, this is you. You know how to do this. You know how to close this. You have an opportunity to be a hero. Help that patient. Get them mobile again. Give them their freedom back.
Oh, that's beautiful. So today, Dr. Matthew Garoufalis reminded us that oxygen is not just a gas, it's a cellular energy, angiogenesis, immune defense, collagen synthesis, and the difference between tissue survival and tissue death. And maybe the future of limb preservation is not just about seeing wounds either, it's about understanding them deeper. And that's why Limb Watch exists. So today, we thank you so much, Dr. Garoufalis, for helping us build where fewer limbs are lost because wounds were finally being understood before they become catastrophic.